We're just 2 minutes past 2, so we will start the meeting. First of all, a welcome to our ICB board meeting. Welcome everybody to this meeting. Can I particularly welcome Katie? This is your first meeting as our Chief Executive. I know it feels like you've been here for ages. Hannah, this isn't your first. It is your first as well. Second, fine. And Andreas, your second as well. A reminder that the meeting is being broadcast online and recorded. The recording will be uploaded onto the ICB website after the meeting, and a version with British Sign Language will also be produced and uploaded. When talking, can members remember to use their microphones so that the broadcast works? It also will link into a hearing loop should any of the members of the public require it. Thank you. Just a point to note, this is a meeting held in public, not a public meeting, so any questions from members of the public or other colleagues not part of the board will happen at the end of the meeting should there be time. We have received apologies from Dame Kelly Palmer, from John Byrne, from Jamal Butt, from James Blythe and from Martin Spencer. I had received no other apologies, and I'm looking around the table. I don't think there are any other people missing from around the table. And I can confirm the meeting is quorate. A register of interests is included in the pack of papers. Can I just check with members that all declarations are fully up to date? I'm not seeing anybody raising their hands, so we can take that as read. So if we could please note the register of interests. Could we move on to the minutes and actions arising from the ICB held on the 15th of January 2025? Are people content that the minutes are an accurate reflection? Thank you. We'll approve those. And the action log has been updated and all actions are closed. Ben, if I can go to you to give us an update on decisions made in other meetings.
Thank you, Mike. So the board met on the 15th of January to approve a number of contract extensions. So the board approved a contract extension to the Integrated Urgent Care 111 contract and also to 3 community contracts for a period of up to 2 years.
Thank you. Any questions for Ben in relation to that? No. Thank you. Move on to the Chair's report. I have given you a written Chair's report. I just wanted to draw out a couple of items. First of all, to note that Ramadan has started, so we will be mindful of our colleagues in relation to the requirements of Ramadan, and we wish our colleagues who are undertaking Ramadan all the very, very best. Also, over the course of the last 2 months, we have had International Women's Day, and I know a number of our trusts celebrated that quite extensively. We also had LGBT History Month, and I know, again, a number of our trusts and partner organisations had a series of events around that. So if we could note that. It's also National Hydration Week this week, and we had a celebration of it at the ICB. It was really fantastic to see Charlotte and her team in the hydration team and to hear about the work that they've done in actually piloting some work for NHS England in relation to hydration in both care homes and domiciliary care settings, and some really significant results, including from participating care homes, 0 LAS UTI journeys from those participants. I mean, it's a really, really significant transfer, bearing in mind that I think something like between 10 and 15% of all ambulance conveyances, blue light conveyances, are UTIs. So really, really significant intervention. That's all I'm going to say. I'm happy to take any questions on my report. As I say, there's a written report in there, but I suggest we might want to go to item 4 on the agenda, which is what matters most to our communities. And I'd like to give a big welcome to Andrew Brown, the Chief Executive of the Croydon BME Forum. Really good to see you, Andrew. And I'm going to hand across to Charlotte to lead this particular item. We will take questions at the end, but I'm not going to take any questions during the course of the presentation, if that's okay for colleagues.
Thank you, Mike. So this paper today is really about sharing with you our latest analysis and feedback and insight reports from our communities across our 6 places. And it is important for the board to receive this because a lot of the engagement we do with our communities is focused very specifically on people who experience health inequalities, and we know that that often leads to the poorest health outcomes. And as Mike has said, Andrew is going to bring to life one of the projects that your organisation's been working with, where the reach and trust of the Croydon BME Forum is helping us collect some really powerful evidence to help us improve people's life chances in Croydon. And Andrew is the Chief Exec of the Croydon BME Forum. But before Andrew just talks about the programme, I think it's important just to understand why what matters most to our communities is important now, so today in the context we're operating in. So the NHS is currently facing 2 challenges, isn't it? Just 2. The first one is managing today's pressures. And then the second one is planning to reform the NHS around those 3 shifts that we're hearing about. So I think to help us deliver for today and then plan services for tomorrow, patient experience and the feedback from our communities must be on the same footing as the operational data that we look at. And this is really, I suppose, because we need to look at not just the data, but the meaning behind the data that we collect and the impact of the changes that we make on our local communities. And also we all need to be joined up, don't we? Because we know that our local citizens don't live in our organisational silos. And the gaps of care, you know, the gaps we have between our organisations affect those communities with the poorest health outcomes the most. So in your packs, if I can take you to slide 29. So slide 29 is my favourite picture. And I know you know this, but I think it's helpful just to reflect that we spend the NHS pound more wisely when we listen to the people who are using our services. And I know you know that. So skip on to slide 32. And you'll see, I just wanted to say our data is very much, our engagement is very much data-driven and targeted. And then if we go on to slide 34. So this just talks about the 5 different ways that we engage communities across South West London. So we use existing insight. We do a lot of work with our partners in the voluntary sector and with Health Watch. We do our own kind of activities around focus groups and events. And we do a lot of digital and online engagement, which really helps us reach, you know, really large numbers of patients and communities. But our community-led engagement is particularly effective when we want to hear from communities who don't want to engage with the NHS and who don't trust the NHS for a number of, you know, really valid reasons. And as you know, these communities often have the poorest health outcomes. So Andrew is going to start by talking to us about the Neurodiversity Listening Project in Croydon, where people's experiences of discrimination have, you know, can lead people to avoid coming forward for diagnosis or treatment and really affect people's life chances. So Andrew is going to talk about that, and then we're going to come back.
Thank you. Thank you, Charlotte. Good afternoon, everyone. Thank you for inviting us. And first of all, it's nice to see so many faces I've seen over the years. Elaine, nice to see you over there as well. Thank you. So my name's Andrew Brown. I'm the Chief Exec of Croydon BME Forum. And just before I do continue, sorry, it's actually Neurodiversity Week as well this week as well. So that's another one to add on to the list, Mike, as well. So my name's Andrew Brown, Chief Exec of Croydon BME Forum. We are an organisation. We are now 21 years old in Croydon, and we also recently won or came runners-up in the GSK Award 22-23 as well. Out of 440 organisations, we came in the top 10, which means which was very hard work because it means we have to get ourselves in order. But to actually come in the top 10, we really appreciate of that award. We also work with the hardest to reach in our communities. And when I say that as well, mainly the global majority people or the BME people, i.e. African, Black Caribbean, Asian refugees, and all of those Eastern Europeans, all of those kind of categories that we see on our list. But that also includes the elders, the younger people, and also families as well. And the way how we do that is by making sure that we include them in the way how we do our projects, which means that they start to trust us the way how we deliver our projects. So as I said, we've been rooted in our community over 20 years, and a lot of the way how we do stuff is by collaboration with other charities as well, such as CVA and also all the other groups as well. Talking about mistrust in our community, because we have to be real, where people come to us, they say, why, basically they do not want to go to the NHS to get to access local services. We've all just come through five years ago throughout the COVID, and we know that the BME community were mainly the main communities that did not trust the NHS to go and get themselves vaccinated. So one of the things that we've decided to do was create a project called the Neurodiversity Listening Project. And when we're now talking about people who do not trust the NHS or do not trust health, one of the young people who actually, well, I say young, he was in his 40s. He started, well, still it depends on how old you are, isn't it? But a little story about him. So we managed to actually have do a case study on him. He's a builder, a very successful builder, but he's actually comes under the word neurodiverse. He can't read and can't write, but he's got one of the most successful businesses in Croydon. But he felt comfortable enough to come to us and tell us his story. And when I said to him, so how do you run your business? He says he gets his wife to do all of the accounts and to read all the letters, and he gets his son to do his social media. He said he's never spoken about that to anybody in his whole life. He didn't know that there was even an opportunity to kind of have an opportunity to actually give that experience to anybody. So for him to be able to come tell us that story was one of the good case studies that we had during this particular project. We engaged with over 550 people during that 1-year project. And when I'm talking about engaging, we ended up doing sessions during the day, but also in the evening as well. And when I say in the evening, we're talking past 6 o'clock. So we're talking about, where they once again can come and feel comfortable speaking about their experiences. We worked with doctors, and we worked with the researchers from universities as well. And we also had events on Saturdays and Sundays as well. Because if you want to hear from the community, you cannot expect the community just to be available between 9 a.m. and 5 p.m. We have to go into them, and that's how we started to build up trust. Or that's how we do build up trust within our community. So insights from the survey itself, and if you just go through the slides as well, we're talking about the main two insights that we have was about stigma. And stigma, even in 2025, is still a major issue in our communities. We would think that in 2025, we've maybe broken down all of these barriers. There are still barriers within the NHS, within the police force, within the schools. There is still stigma within our communities. A lot of our families, especially within these 550 people, they were fearful of being diagnosed. Now, if you can imagine that a parent does not want their 2/3 children to be diagnosed with a condition because she thinks that's now going to make her children be labelled within school. And that is the reality of what is still happening in 2025. limited availability of black neurodiversity professionals within our communities. So that's one of the recommendations that we've actually come up with, is that we want to train more professionals to actually be more neurodiverse, trained up, but also can we get more black professionals trained up in neurodiversity. Once again, if we want to break down the barriers, we need to be able to train up people who look like the communities as well. And one of the main aims of the engagement was to hear from our communities, often feel who, as I said, who are unheard of and misunderstood. A lot of the work that we've done is with SLAM as well. So, you know, SLAM, mental health, once again, another big stigma in our communities. Working with them and actually have them actually giving us 2 members of staff for a whole year, once again, broke down the barriers as well. And once again, it made them understand the things that they now need to do and change within their organizations as well. So it says here that we've got a report. I'm happy to say our report is finally published, and it is here, and I'll leave a few copies here as well. But I would say the main thing that I think one of the things I really want to do today is to really emphasize is how we move to the next step as well. One of the recommendations that I would like to offer is how we can train the people in the NHS. How can we train our lawmakers? How can we train the people in schools as well? Because if we can try to get people trained up from a young age, yeah, means that, so if we can try and train the professionals to work with people at a young age, it means that they'll have a better life and a better living life when they're growing up, when they're growing up as well. How can we stop that 40-year-old person from going through all life without saying to anyone that he cannot read or write? That should not be happening in 2025. That's my few words. Thank you.
Thank you, Andrew. And we'll take questions at the end, but obviously we'll be supporting Andrew to make sure that all the great findings in the work that you've done actually have impact across all the different parts of the NHS pathway. So we've talked about why community engagement is so important as we go forward and transform the NHS and as we become more productive. And we talked about how we reach kind of deep into communities that experience health inequalities to help them access health services. So now, if you turn to slide 41, I'm going to give you the golden nuggets and highlights of 3 significant pieces of engagement work that we've done over the last year. So these are, you may remember them, the 10-year plan engagement exercise we did, a bottom-up analysis of over 270 engagement feedback reports we've done up to January 2025, and then some early feedback from our winter engagement activities that has been supported by both Jonathan and Matthew through the Urgent Emergency Care Board. So I suppose important to remember, I mean, I'll just give you some quick highlights, that this feedback is from our communities who experience health inequalities. So it might be different to other data sets you've seen because those data sets will be across a much broader base. So this is very specific to those communities. So if you go to slide 43, let's just talk about the 3 shifts. So the first shift, moving care from hospitals to community. So what we found is people are generally very positive about this shift. But people have said that services in the community can be a lot more difficult to navigate than just going to the hospital, so they would need help with that. I think that's important. People also talked about their concerns about home-based care, and they were worried that it would mean that people would be sent home to from hospital with no support. There was lots of conversations about the need for oversight of the whole system so that the care we provide isn't fragmented, and lots of suggestions that the voluntary sector can offer cost-effective or really cheap options to look after people as they leave hospital. I'll go on to slide 44. So shift to making better use of technology. So what was really interesting was important to everybody, so not just the digitally excluded, was the importance of protecting the human connection. And I think that's important for us all to remember. There was also a perception, brace yourselves, that the NHS doesn't do technology very well. And that is connected to people's concerns about their data security, apart from anything else. People also told us, you just need to get the basics right, folks. You need to make sure your systems talk to each other. I know that's easier said than done. But they were also real concerns about finances and people's personal finances, and that it was actually expensive, you know, to be able to connect to the internet and pay for data. So there were those concerns as well. But there was also positivity. So there was a real feeling that digital information can empower people to kind of look after their own health. So ending on a positive. Shift 3, so slide 45, focusing on preventing sickness, not just treating it. So, again, brace yourselves. There was a belief from many of our community leaders that the NHS is just too short-sighted and too short-term when we think about prevention. And community leaders said, look, you know, come and talk to us. You know, we can help the NHS at neighbourhood and at street level to have really good conversations about prevention behaviours and really good activities. There was also, and throughout all of these 3 pieces of engagement, really good advice about making use of the long-standing relationships that communities have with pharmacists, so as well as GPs. So pharmacists really are at the heart of a lot of our communities. And then I think finally a belief from almost every community leader we talk to that the early years of a child's life must be prioritised in terms of our activities. And my favourite quote was, the NHS should be focusing on babies in the womb, not just health checks for the over 50s, which I thought was quite good. So that was the 10-year plan. So moving quickly on to the second piece of engagement. So this is a more bookish, nerdy exercise of looking at over 270 reports. And this is really about starting with what matters most to communities. So what we do a lot in the NHS is we say, hey, what do you think of these plans? Tell us what you think. This is the other way around, so it's far more bottom up. And you'll see on slide 47, quite a busy slide, but looking at all of those reports, there are 17 themes that matter most to our communities. And you remember we did this last year as well, didn't we? So if I just bring your attention to the rising concerns and new entries, if you like. So again, early years comes up. So, you know, our communities are saying to us, early years and children are really crucial in improving health outcomes in the longer term. Supporting children and young people with special educational needs, lots of conversations this year, more than last year, and increasing concerns about how poor housing is leading to worse health outcomes, and the cost, again, of travel. So all of this is obviously linked to the cost of living increases. We then did a piece of work where we said to communities, okay, we've got community leaders in the room, we've got 17 key themes, what are your top 3? Because 17 is quite a lot. So the top 3 are, so inequalities and inclusivity. So our populations that experience health inequalities and the worst outcomes, we hear loud and clear communities telling us that they feel their ethnicity negatively impacts the NHS care they receive. So all of these reports are telling us that people's experiences of discrimination make them less likely to come forward for the things that we want them to come forward for. So screening, checkups, tests, even when people are unwell. So there is, as Andrew has pointed out, a lack of trust in NHS services by significant sections of our population. Mental health, as we probably expect, continues to be a big issue, particularly for children and young people. And then the third one really is about community services and activities, and carer and peer support groups are really highly valued by our communities, as is kind of going to trusted places where our residents in these communities can feel safe and supported. Okay, and then finally, if you just go on to slide 51, so this is the high-level feedback from our winter engagement activities. So if you remember, I think I've talked about this before, we fund voluntary sector organisations a few £100s to go out and talk to communities about the things that are important to us in the NHS, so around pharmacies this year, the NHS app, vaccinations and immunisations, but we also then listen to the concerns that our communities have got about health and care. So between, I think, November and the end of February, beginning of March, we have had 10,000 conversations with these targeted communities. And if you look on slide 54 and 55, these are just some very high-level sort of top lines for you. And some of this we would expect. So, we've seen, haven't we, national studies and feedback from local people about their concerns about long waiting times, GP services, support for the NHS and praise for the staff, and then polarised sentiments around vaccines. So we'd expect that. But more concerning from these populations, with the poorest health outcomes, remember, is firstly challenges with language translation and communication. So this was raised frequently as a critical barrier to people accessing and seeking support. People also said that they felt unheard and not respected. So we have got a range of feedback from people saying they felt they weren't taken seriously by healthcare professionals and administrative staff. And sadly, we have quite a lot of feedback about people feeling scared, particularly of busy services. There's a lot of kind of digital entry to services being very off-putting for people. So it's kind of a mix. So people were very positive about the NHS app, but there was very, very strong feedback that people found digital access to some of our services extremely challenging. To end on a positive note, again, pharmacists are the people who kind of come out top of all this engagement. So people really, really trust their local pharmacist and find their local pharmacist easy to access. On the flip side, in some groups, there was really not much knowledge at all about the potential of pharmacists to help local people with a wealth of kind of health conditions. So that's three pieces of work I've told you about very quickly. 2 of the reports are on the website already, or just email me and I can send you them. And the winter engagement report is just being finalised. So I guess on the back of, that work, I suppose I've got 5 recommendations which are in your pack. So the first one being, let's keep the culture of engagement feedback at the heart of everything we do. So we have got a good culture of this in South West London. If you think back, remember the clinical conference, remember those local health and care plan events, all the work that the Cancer Collaborative has done on low uptake groups, all the engagement work at Place on kind of service change and improvement. So it's about keeping that going. The second recommendation is let's make engagement everybody's business. We can help programme teams with collecting new insight or seeing what insight from communities is already there. The third one is building on what we already know. We don't always have to start with a blank page. There is lots of engagement insight out there if you know where to look for it. Number 4, I think, is probably the most important, and that's about asking the right questions to the right people. We have to make sure that our engagement seeks data and insight from people with those poor health outcomes, don't we? And we have to make sure we view this data on the same, footing as operational data. And then finally, it's about understanding into action. The more we talk about how people have influenced what we do as a result of engagement, the more it builds trust and increases engagement going forward. So it's kind of like a snowball effect, isn't it? So I suppose what I'm recommending to the board is that you take this learning back to your individual organisations and think about how we can use it to kind of deliver and transform services. Thank you, Mike. We're happy to take questions, aren't we, Andrew?
Yeah, we'll move to questions. Charlotte, could you just say a little bit more about how people can access the Bank of Insight and how you'd like to see the partner organisations around here promoting that?
Yeah, so we've got the Bank of Insight on our website. I have to say, if I'm really honest, it's quite difficult to get people to share their insight. So we have been on a bit of a campaign around South West London organisations, but if you have any engagement insight, and I know local authorities particularly have a huge wealth of insight information, if we can just share it together, that would be really helpful. So it's currently on our website. I am considering whether we need to have it on an independent hosted site so it doesn't feel too NHS-y. So we might look into that so it looks a bit sort of more neutral and a bit more shared. So we could possibly look into that. But it really is and the other thing I suppose to say is it is quite irritating for residents if we go out and we all ask the same questions to a lot of the same people. So if we wanted to join it all up, using that Bank of Insight is really important.
So that could be a good example of some of those ways in which we change the way in which we're working to get more value, because I think all of us would agree that we wouldn't want to. Now we're beginning to build a culture of engagement. We don't want to disband that. Actually, that's the way in which we can ensure that our services are cost effective as we move forward. Hannah, I'm just wondering whether you'd like to come in, because you're, as our local authority chief exec.
I mean, I think, Charlotte, your point is absolutely right. I mean, if you talk to residents, they get a little bit fatigued at times as well. So I think we've all got very good intentions, haven't we, as organisations around that engagement and communication. But residents do feel they tell the same story over and over again. I think it would be really helpful if we got the South West London comms group together, Charlotte, and with you. I see no reason why we can't share some of this and join it up. And I think then it's where is it best promoted. So very, very happy to support that and start those conversations across the boroughs.
Oh, thank you, Hannah. I may use your name in vain.
I'll go to Anne next.
Thank you. It's very, very compelling. Can I just ask about the cultural competence point that was made that seems to be at the root of the sort of health inequalities issues? Is it possible, do you have recommendations about particular areas we should prioritise? Obviously neurodiversity was one. I know sickle cell in other areas is another, where, you know, I'm just thinking about how you start to have an impact on this. Did you come across there are particular services where we could make a start, where this is particularly pronounced?
Yes, thanks, Anne. So I think, so I'll let Andrew come in about neurodiversity, but I think actually we could probably do some really good work with primary care. So if we think about 90% of people's experience of the NHS is with primary care, and I think, you know, so I've got loads of recommendations, but we can't do all of them. But I think, you know, there's lots of work we could do really around metrics, really, but also coding. So in primary care, you know, we've heard a lot about coding, and how do we know how we're doing if we don't know, you know, we haven't got metrics about the people we're seeing or not seeing. I think we could also think about targeting. So we have, you know, that slide. We know where our communities are that experience health inequalities. We know where that core 20+5 group are. We can match that up with engagement intelligence, and we can actually probably target particular practices to go in and support. I mean, Nicola will have views on this as well, but I think it's, you know, a lot of it, I think, is probably unintentional, and it is, as you say, about cultural competencies and actually good conversations. So when we go out in community, we see kind of clinicians and communities coming together and talking, you know, transparency around experience as well as data is really powerful. And the only final thing I would say is around translation services. So we might want to have a look across South West London at translation services, both the quality of them, you know, could we come together and improve translation services and then monitor the quality of them. So quite a lot to think about.
I would say cancer. So we've been funded by Macmillan Cancer Trust to deliver in the whole of the South West London arena cultural competency training to professionals and to doctors. So on Monday, I just trained up all of my 14 members of staff to be able, so that they are aware of the latest things, and they're now going to be going into St George's, CUH, all of those hospitals, and start training up the doctors, the nurses, so that they are up to date on what to say and what not to say, and et cetera, et cetera. So that's what I would definitely say regarding cultural competency, yeah.
Thanks, Andrew. I'm going to go to Nicola, Shannon, and then Andreas.
Yeah, thank you. Great work, Andrew. Thank you so much. I really enjoyed listening to that. And I just wanted to focus really on the elements that relate to primary care provision, because it featured a lot in that, really. But, you know, it is fair to say that it's not new, right? It shouldn't surprise any of us. And there's been other, you know, recent report published from the Race and Health Observatory, and they found that people from ethnic minority groups had lower levels of trust in their primary care clinicians, and we include in that GPs, midwives, community nurses and pharmacists. So there's something important there about this, and you know, they experience discrimination, and I think it's no surprise that people who face discrimination in that that setting then lose trust in their care providers, and then they find it difficult to access care in future. So, you know, that's what we're seeing, I think, and it's complex, clearly. And you know what, it's really hard to hear a message like this about primary care, but I think as a board, it's really important that we hear it. And making sure our healthcare is resourced locally so that people are able in their work to listen to patients and to respond to their needs and respect them as individuals, because that's the basis of equity, isn't it, when you start to look at people as individuals. I think that's really important. So, and Charlotte, you talked about loads of the engagement that's happening, but some of the ways that we actually do some of this stuff. So our women's health hubs that are evolving, you know, they've been designed to make sure that women, particularly black women, who feel that they're not listened to, are able to address their healthcare needs in that setting. And we've got chronic kidney disease. So we've got some great work going on there, which is really important, culturally sensitive stuff, because it's about people's lives and how they live them. It's about healthy living. And if you deliver that insensitively, it just won't hit the mark, will it? So that's really important. And then in Wandsworth, we've got our mental health improvement programme, which is looking to reduce health inequalities in mental health. Really, really important. And it's co-produced with communities. That's the only way you can really get to the bottom of some of these issues. So they're kind of small examples, but you know, more broadly, we need to address this through everything we do, and we need specific mechanisms for addressing it. And so people have mentioned some of them, but I kind of just wanted to flag a few that I was thinking about, really. So this development of cultural competency skills, absolutely. You know, we've got a delivery device, we've got a training hub that can do that kind of thing. Interesting to think, though, that the staff in general practices, pharmacies, etc., are drawn from their local community, and when you take that bit of, that's important to influence how we do all of this. So that's key. And then interpreting services, we've just commissioned a new interpreting service right across in primary care. Making sure we use that really well has got to be an important thing. It's no good just having it, we've got to use it. Coding, ethnicity, and people's risk for their health point of view, combined with their ethnicity and other elements that affect their experience of health inequalities, is really important. And then, deep breath, the operating model in general practice, which, you know, we need to really do important work on that to make sure that people can get the care that they need. And Charlotte, your message about asking the right people the right questions about that particularly, I think, is really, really important.
I'll get the rest of the contributions, and then I'll give you you and Andrew an opportunity, Charlotte, to say some words at the end. If I could go to Shannon next.
Thank you very much, Andrew, and congratulations on the achievements of Croydon BME Forum. It's interesting because I think it's already been mentioned a few times about kind of engagement fatigue with communities, and one of the things that I'm not so sure we do well at a system level is, you know, retaining some of that learning which is very specific around particular communities, and then actually embedding it in the work that we do, whether that's at a strategic level or whether that's through our service planning. So a lot of times we go out and we engage with communities. They're still happy to engage, but they feed back that, you know, they don't necessarily feel that that engagement then impacts in terms of the services that they receive. So I wondered whether you had any reflections for us as system partners in terms of your experiences over the 20 years around this kind of engagement fatigue, and what you think the system could do better in terms of its organizational memory.
So Andrew, if you can hold that for coming back. I'm going to take a couple more questions. So I've said Andreas, Masood, Annette and Mark, and then we're going to have to wind this up. So, Andreas.
I think Mike Alissa wanted to come in as well. Just on the list of people she had lined up earlier on.
Sorry, who did?
Oh, sorry. Thank you, Andrea. That's very gracious of you. I just wanted to really compliment Charlotte and her team. As Health Watch, we work very closely with them, and I see firsthand just how much work goes into engaging really into a lot of different communities across Southwest London. I also just wanted to say that Health Watch is available to help you take forward some of the recommendations that Health Watch that Charlotte has included in her packet, especially around embedding a culture of engagement throughout the ICB. And just to note, we've done some recent work as well with neurodiverse and other disabled groups across Southwest London. Andrew, I know we've been in touch about this. And just wanted to say that we've started a new Southwest London-wide community of practice that includes representatives from the ICB, people with lived experience, GP practice staff, and we would love for you to attend those and share the learnings from your project as well. And just a note about the new interpretation services in GP practices. HealthWatch is doing some work right now, rather limited in that we're just talking to users of the BSL language service to get some preliminary feedback on how that's going. But stay tuned. We'll have insights about that soon. Thank you.
Thank you, Elisa. Masood.
Thank you. Some really good insights. A couple of questions, and apologies if I've missed it. What was the total size of the fund that went to the 115 groups? And then when we look at the how those groups were chosen, were there other criteria involved? So did we look at things like multiple index of deprivation, ethnicity? I know we've talked about neurodiversity and so on. And then with the learning, are we linking that to any outcomes or reduction in certain health inequalities? And it may be that it's too early, but have we got that on the roadmap so that as the data builds up, do we triangulate it to actually assess the impact? And with that data and with the links we've got with our communities, is the data and are the people actually feeding into our commissioning decisions? So are we moving to a model of co-production rather than, if you like, we do the consultations, but actually the group that we're engaging with then feel a bit left behind in terms of not making the decisions? Thank you.
Thank you.
Oh, sorry. And are we looking at digital solutions for language? Fine.
Thank you. Andreas, I will come back to you now.
Thank you, Chair. Yeah, thanks, Andrew and Charlotte, for the report. I mean, this is really absolutely, immersing work and a lot of interesting insights and learning. And I just think it's an opportunity for us as a system. I think for many of the challenges we face, volunteer community sector, local government, and the NHS, we got answers from the engagement session you've done. Early years has been mentioned, prevention has been mentioned that people think the NHS can't do everything. They think there are other players should be in the place as well. So I think taking this really seriously as an indication there is appetite from our residents, and really, there's more we can do in working together on the set strands. And I think this is really encouraging engagement work. And I just think we would miss an opportunity if we're not really listen and try to learn from it and really do things differently.
Thank you. Mark. Sorry, Mark and then Annette, and that's it. Sorry.
First of all, thanks for the presentation. Really powerful feedback, I think. It's just picking up on Masood's point, because myself and Hannah had recently been involved in a local authority peer review, and actually the continuum between engagement and then through to co-production, because although NHS, the diagnosis and treatment, that's at the back end of the patient journey, isn't it? It's how people actually co-produce the access points and also the information, because what we tend to do is we tend to put it in the leaflet and we translate it. Might not be culturally appropriate to do that. So I think there's something about us co-producing some of the solutions into the services.
Thanks, Mark. Annette.
Thank you, Mike. Andrew, really good to hear about your project and your forum as well. I think some really good work going on, and I think neurodiversity is such an important area, and your engagement seems to have been so comprehensive, which is really good to hear. I was just thinking about how we could improve people's experience of primary care and the way in which services are delivered and the way they feel when they access those services. And I think we might have an opportunity with our PPGs, our patient participation groups, but I think we could really do with the support of the voluntary sector and people like HealthWatch to try and, I suppose, increase the awareness of that amongst groups who otherwise wouldn't engage with PPGs, and to get some representation on those patient participation groups, because there's a real opportunity, I think, there to have a voice, to influence how those primary care services are delivered, and therefore to change perceptions and have some autonomy as patients into that delivery. And then I just wanted to say something about our interpretation services. So it's really good, and I know that Healthwatch are looking into our interpretation services currently. Can you please speak to primary care when you do that as well? Because I think we still have some shortfalls in our interpretation service in certain languages, and I think it would be really good to give those of us working at the coalface, particularly because I think in those areas where we still have some shortfalls, those are patient groups who would not normally engage, and so I think it'd be really good to just get the primary care perspective as well to try and improve that for those groups of patients. Thank you.
Thank you, Annette. So, Andrew and Charlotte, do you want to sort of give some highlight response to that? But I think what you can see is there's an endorsement of the approach that you're taking, some significant offers of partnership working to take forward the recommendations that you've included in the report, and enthusiasm for continuing with our commitment to engagement.
Okay, thank you. So I've tried to write down, as Charlotte's looking at my notes like, what the hell are you doing? So let's start with Shannon's ones first. Engagement and fatigue is what I got from what you were saying, sir. I would say making sure that we go back to the community with the answers. I think what we do a lot, and our organisation, we ask all the questions, but we never go back and actually say, this is what you guys have said. So I would definitely say events and feedback sessions, and the black community, and I say the black community in particular, we do want to get involved in research. We do want to get involved with activities from the NHS, but sometimes we just don't know how to. So one of the questions were, have you ever done any research before? And the answers for the Black African Caribbean was so low, because we might see it somewhere, but we actually never been engaged with how to actually do research. So let's make it more open. Co-production, and Mark and I think over here, said about co-production. So we've just finished a funding program with the Maudsley Charity Trust, and the way how they done it was they've asked us to go into a community and get lived experience people who have suffered from psychosis or have looked after someone with psychosis. So when we put the call out, we didn't know how much we were going to get. We ended up with 20 individuals who have now managed the program, gone into community groups, awarded funding to those organisations. Well, sorry, the awarding will be happening on the 25th, but they've gone into each of those organisations and have sat down with somebody from Maudsley and has decided, should they win funding, should they not win funding. And on Wednesday, they're now going to decide the 12 organisations who's actually going to do it. When we started the project, Maudsley said, no, we want you guys to come with us, but we're going to make the decisions. Yeah. Halfway through the project, they've totally changed their mind now and said, no, we're going to do the decisions together, because they maybe thought that we weren't able to do it. But we're talking about professional people. We've got people. We've got the manager of CQC as part of the part of the lived experience. We've got teachers. We've got professors who decided they wanted to be part of that. So trust us. Yeah, trust us to be able to work with the NHS to make the good decision for our own communities. And I would say that's my main thing, is trust the communities to be able to make decisions for communities.
Have I got 1 minute, Mike, just to quickly come back. So I just want to say, brilliant. So I think further conversations with Hannah, Andreas and Nicola, I think we could really get some good stuff moving. Masood, I think you're totally right. So demonstrating the return on investment of engaging with communities is the top of our list. And I think, when we look at kind of metrics, we did a lot of metrics around vaccinations and immunisations. So that's the really clear and easy way we can track through. The cost, so we offered organisations organisations up to £500, those 115 organisations. But that's not a one-off, so if we think about, so the board will remember Sandra when she came back, so that £500 enabled her to give her Afro-Caribbean elders a hot lunch once a week for 6 weeks to have those ongoing conversations. So obviously we think that is value for money. And just on co-production, so I think it really is important to start early. So over here, I think someone was saying, you know, it's getting involved and getting patient views and community feedback almost before you've had the idea of what you want to do, because it makes you think about what should we do that's important to our communities. That's really important. Difficult to track that, but I think that's why I'm grateful for this opportunity at the board meeting to say, this is all the data, this is what communities are telling you that matters most to them. Let's think about, you know, the priorities we set and the work we do with our communities with this as the baseline. So let's start here. Thank you, Mike.
Thank you. I mean, I think you saw a lot of enthusiasm for the work that's been undertaken, a lot of commitment to it. Charlotte, thank you for bringing the report to us. Andrew, thank you for joining us. Really nice to see you again, and you really brought to life the programme of work for us. So thank you very, very much. We will move on to the next item. Martin, you have a challenge now to get the room as innovated as the last item. And you're going to be talking to us about our cybersecurity strategy.
Yeah, I was just thinking that's going to be a tough act to follow, particularly with cybersecurity. So thank you, Chair, and welcome. Hi, everyone. So when ICBs were set up, a few years back, we were given accountability for assuring that cybersecurity risks were being managed across the NHS within our patch, and also for coordinating cybersecurity incidents when they do happen, because invariably multiple organisations are impacted given the way we now integrate systems. So if you look at the recent experience we had next door in South East London with the Synovus attack, which essentially took away the pathology services for the NHS, that had significant impact and basically stopped a lot of clinical services. It's now in the public domain that cost 33 million, that the impact, it was the financial impact of that incident, never mind the cost to care, because it led to delays in treatment and the way we deliver care significantly. So it had a huge impact. We've had our own cyber incidents on our patch. Not so long ago, we had Advanced Healthcare, which about 2 or 3 years ago, they had a ransomware attack, which took down the electronic patient record systems in one of our community providers and in one of our mental health providers. And also for 111 services, it impacted significantly for us, but for other 111 providers, it took theirs down as well. So this is a very real threat. We're living in an ever increasingly threatening cyber world with the geopolitical movement at the moment. I've heard from the national team that up to 100 attacks on the NHS a day, which pretty much all are fended off, and thankfully at this point. And a lot of the attacks seem to be with third-party organisations at the moment that are being successful. But they are quite few and far between, but we're seeing a rise in attack on the NHS. So each ICB is required to have a cybersecurity strategy in place, and we've worked together across South West London with the NHS providers, through our cyber assurance group and through a lot of evaluation assessment of our cybersecurity stature. And off the back of that, we've developed a cybersecurity plan and this strategy. And this strategy aligns with the Department of Health cyber strategy for up to 2030. It also fits within the What Good Looks Like framework. It will align to the new cyber assessment framework, which replaces DSPT. We have a risk on the board assurance framework for this very thing. So risk 149, interruption to clinical and operational systems due to cyber attack. And it is a red risk for the ICB. So our vision is to establish a digitally secure and resilient ICB, where leaders champion cybersecurity, encouraging a culture of shared responsibility across NHS providers, organisations and the wider ICS. And in the document you'll see we've got six objectives set out and how we will go about delivering them. There isn't the detail in this document because you can appreciate if we reveal that detail, we're revealing our vulnerabilities from a cybersecurity point of view. However, I want to assure the board there is a detailed plan that sits behind this that is overseen by the digital board. And John Byrne, CMO, is the chair of the digital board, and he is the exec lead on this board for cybersecurity. It's been through governance to get to this point. So the Cyber Assurance Group recommended it to the digital board, who recommended it to SMT to bring it to the ICB board for approval. And as I said, it doesn't include the detail. So the board is asked to note the contents of the report and to approve the cyber strategy for the ICB. And this will complete the suite of documents for digital with the digital strategy, the data strategic plan and the digital inclusion toolkit. Thank you.
Martin, thank you very, very much for that. I'm not proposing to take any points on this because we did have a lengthy discussion, a seminar session about 6 months ago on cybersecurity, which I know was part of the process of coming towards the strategy. And I can see that the discussion that we had there has been incorporated into this plan. So are people content to accept the recommendation of the digital board and approve this strategy? Thank you all very much. In which case, we will now go for our scheduled comfort break. And I suggest that on the basis we did run the part 2 right up to this, that we take the full length of the comfort break and reconvene at 3:15. Okay, people, we're going to make a start on the meeting. Okay, thank you all very much. I hope that you've had a refreshing break. We're going to start the second half of the meeting now, and item 6 on the agenda is the NHS Green Plan, and I'm going to ask Helen to introduce this item. Just again, we have had a seminar on the Green Plan and discussed it at our last meeting, which was kindly hosted for us by Kingston. Over to you, Helen.
Thank you, Chair. So, as you know, we had a 2-year green plan that ends on the 31st of March, and we've been reporting to this board every 6 months and giving updates and highlights of what we've achieved. So we've had the GLA come and talk about adaptation, and we've had some examples of what's happened, and actually at Kingston Hospital is really great because your clinical lead came and talked about some of the work that had been done in maternity and around how that had helped address health inequalities as well as greener. So it's when all these things align, isn't it? Because actually green needs to be embedded in what we do so that we're saving money, we're making the quality of experience, we're opening access, whilst we're helping to reduce carbon as we go. So just wanted today to talk to you about the key highlights for the last 12 months, which will go in the annual report, which is part of your pack. Really, really pleased that we've managed to strengthen the partnerships across the patch, particularly with the GLA and what we've done in the roundtables that we've managed to run. That actually we've really expanded on the sustainability training and resources for the workforce to raise skills and awareness. And actually part of what we talked about last time at the seminar was how do we have like a personal checklist so people understand the impact that they make. So we're starting to work on that. And we were successful in securing £4.5 million into reducing emissions through LED lighting and building management systems, etc. in year. So really great to bring some additional funds into the system. During the year, we started to actually count the carbon reductions, and we started to really improve that data and evidence that we have. And what we want to do is go on and look at what does that mean when we invest and what savings we make and the economic benefit we have, which again, we talked about at the seminar. So I think great advances and to build off where we are. So if we look as we go forwards, we've been developing the 25 to 29 Green Plan, and that's what we discussed at the seminar. We've fed that feedback in, as you can see within the pack here, around how to improve that. And we've also ensured that we've aligned it to the national NHS Greener Programme objectives that came out at the same time as the seminar, to be able to take things forwards. So just wanted to bring it here today to hopefully get approval to take that forward, as well as approval for our next reporting into NHS England for the achievements for 24-25. Thank you.
Helen, thank you for that. And as I say, I don't propose us to have a lengthy discussion on this, as we had a really good discussion at the last seminar. Are people happy to note the progress made in 24-25 and submit that to NHS England? And are people content with the strategy for the period to 2029? I'll take Matthew and Zara.
So yes is the answer to your question, but I wasn't, that hand was up for a different reason, which is just as part of this, there is in Croydon we have a bid in to Salix on decarbonisation, which is our sort of second and a half attempt at getting through this national process. If we do, it will secure a very significant investment which will massively help in terms of decarbonisation in Croydon and by extension South West London. The process is quite elongated, and it's not always as absolutely clear how it works, and therefore colleagues at ICB level, Helen through her route, Mike, yourself and Katie, there may be questions that come up, and all support gratefully received, I think is all I'd ask.
I think we can confirm that we will be incredibly supportive of that, and well done on getting so far in the process. Sarah.
Thank you. I just wanted to stress again the need to work with voluntary sector groups that are local when it comes to green groups. I noticed that there is very little mention in the beautiful report of voluntary sector, and the acknowledgement at the end, like the list of acknowledgements, includes one charity only, which is kind of a big national charity rather than a local group. And I know there is some work going on with St George's, and so it would be great to have those, you know, those names there, to have those connections there, and to build more as well.
I'm sure Helen will take that on board. Is that?
Yeah, happy to do so. And I think you've met with Sarah already, haven't you? So we will continue to do that and build off that.
Vanessa.
So I, of course, support the work, and I feel like, given the conversations that we're having around our financial position, whilst this is absolutely the right thing to do, there's a number of things that we're discussing today that take our staff's time, and we're going to need to make a decision about whether we use our staff's time and our resources to deliver on something as important as green, or whether we're going to use our staff's time and put resources to transform the models of care that we're providing. And I don't think those are going to be easy decisions, but I think if we don't kind of note it here now in public, that we're going to come up against these decisions time and time again, aren't we, in the coming months? Yeah, I'll get off my soapbox, but it just feels like we might be operating in a slightly different place.
Yeah, I think both within the partner organisations around the table and within the ICB itself, that will be a challenge in terms of maintaining capacity. What we should remember, of course, is that there is a huge amount of enthusiasm amongst our staff, particularly our younger staff in all the partner organisations, which we could and should be tapping into to help us deliver this agenda. Much of that energy is actually free.
So huge energy, absolutely, which we can tap into, and I suppose it depends on where we want to use that energy most effectively for the safety of our patients. People.
Bob.
Thanks, Mike. I absolutely understand Vanessa's point. I think that's why it's so important that we don't get out of alignment the drive to green with the economic impact and benefits of the drive to green. So I think that helps. In the context of the overall challenge, actually we can align the two and should align the two, or else we shouldn't be making investment propositions in the first place. And the second thing is, in the light of Matthew's hopefully good news, in another place wearing another hat, I'm associated with an organisation that's been very successful in accessing money from Salix, so I'm very happy to help in any practical way I can in terms of process.
Brilliant. Thank you for that offer, Bob. I know Matthew will take you up on that before you leave the building today. I think we're content to note the progress in the last year and to endorse the strategy moving forward. Thank you, Helen. We will now move on to the Board Assurance Framework. Ben.
Thanks, Mike. So, as you all know, I regularly bring an update on the Board Assurance Framework to the Board for noting. So, the Board Assurance Framework, or the BAF, provides the Board with an overview of our key risks, our key high-level risks and assurance against the actions that we're taking to mitigate those risks. The BAF, along with our corporate risk registers as well, are regularly reviewed by the executive team, SM team and our audit and risk committee, and as you can recognise, are continually changing and evolving, although not quite at the pace to reflect some of the announcement and changes that we've had over the last few days. But Katie and I have started to talk about how we may evolve and take forward the BAF over the coming months as we start to learn more about the new operating model for the ICB. Currently we have 7 risks on the BAF. 5 of those are at scores of 15 or above, and the detail of those are within the covering paper and the following risk register, Mike. So I'll take the detail of the paper as read. I'm really happy to take any questions, and I know exec colleagues would be as well if you have specific comments or questions on the risks.
Sarah.
Thank you. So I understand this is a presentation on the current high risks, high impact risks. I wanted to ask whether the corporate risk register includes the voluntary sector, as I noticed that in some of the other systems, they were able to include public sector funding challenges impacting the voluntary sector sustainability and therefore the ability to support and respond to the needs of local people as one of the risks, and then consider, you know, what can be done to mitigate that. Yeah.
Yeah, so I think you're absolutely right to raise it, and I think we have to think about where we put that on the risk register, because I think the voluntary sector is really important for community sustainability, and as we go forward we just need to kind of think about the longer term impacts and how much the voluntary sector actually support us. So we'll take that away, won't we, Ben?
Yep.
Thank you.
Within that context, perhaps we would want to include hospices as part of the voluntary sector in that assessment. Thank you. We note the content of the report, Ben. Thank you very, very much. We're going to move on to the Integrated Care Partnership update, and if I go to Councillor Andreas Kirsch, please.
Thank you, Mike. Yeah, so since I'm in the board, we had 2 meetings so far from the Integrated Partnership, and the last has been on the 5th of March. And we had the Workforce ICP strategy priority there as an item. We were also talking about reducing health inequalities and looked at the ICP strategy again. And we had to get Britain Working Trailblazer in South West London as an item. And from what I found from both meetings, it was really interesting. We had a healthy mix from NHS items and items which were coming forward from the local government background, and always a good turnout with all the other partners in the partnership, voluntary community sector and others, and really good discussions on the items. So I felt very, very positive and constructive, the working in the partnership. I think what is important is not losing sort of any momentum here, but looking that we, have that healthy mix of items so that we have generate enough interest and look at all the areas from the partnership, that everybody feels part and empowered in the partnership. And I think it's also on a lot of work strands or things, that we also celebrate success or come back with things that we see tangible outcomes from the work. And one of the things which I would like to add to the report as well is we just on Monday had the anchor workshop. So again, thanks for everybody who was able to make it. And I think that was again really an interesting workshop where we looked at partnership working and how in a obviously changing world for the NHS and in a changing world for local government and volunteer community sector, how we make the partnership work, how we make most out of the partnership and how we really use that collaboration in the most positive way to in the end help our residents, which we all represent and care for. So that was really a good workshop, which a lot of positive energy in the room. And so I really hope we can come back to the ICP with some tangible outcomes again on a reporting back of the workshop.
Andreas, thank you very, very much, and thank you for highlighting the anchor workshop. It was actually a really uplifting and inspiring day, and it was, I think, a good example of how the ICP could work and be structured in the future to actually deliver real benefit to our communities. Thank you. Any questions for Andreas? In which case, we will move on to the committee updates and reports. We would normally ask Jamal to introduce as committee chair the Finance and Planning Committee. He has given his apologies today, so I'm going to go straight to Helen.
Thank you, Chair.
And you'll pass across to Jonathan, I think.
Yeah, well, for performance, yes.
Yeah.
So at the Finance and Planning Committee held at the end of March, we had a focus around the Green Plan, as we've just talked about, but also an in-depth item about medicine optimisation programme, which has been going for a number of years now. And as well as having a focus on the finances and the costs within prescribing, we also looked at their approach to unwarranted variation and how we would target that as we went forwards, and making sure that we could optimise medicines for patients as part of the programme. We also reviewed the operating plan at the point it was at with the information that we had available to us at that time. Obviously, things have continued to move on, the ICB budget and the proposed capital programme. And finally, we looked at the terms of reference and did an effectiveness survey of the committee and reviewed that of what our thoughts were to put a proposal back to the board for updates to the terms of reference. Within that, obviously, were the finance reports, and so the month's 10 finance reports were reviewed. The ICB remains on plan for the year, although as we've stated before, we've got a number of SIPs that are non-recurrent that's going to make it more difficult in 25-26 for us to make sure that we turn those into recurrent savings as we go forwards. From the wider system point of view, we are £22.5 million adverse to plan with a number of risks in there. Part of that was around ensuring that some of the allocations we were expecting were going to come through to us. The fact that ERF had been capped in December, and actually we were trying to understand that and what the final allocations were going to be. We obviously have the impact of the cyber attack from previous in the year, which Martin referenced. And so actually we now know that we've had a number of those confirmed to us, so that has closed that gap in where that is at. And we're on a journey to be able to deliver the plan for a year. But that will require all organisations and all the trusts to really work hard at managing those costs at the end of the year. This is not an easy place to be, but so there's no taking the foot off the gas, if you like, in managing all of that. And the capital remains on plan for the year. And just wanted to say that the capital plan was required for us to deliver the disposal for South West London St George's, which went through in early March. So that has now de-risked the plan as they've received the receipt.
Thank you for that, Helen. And on the medicines optimisation piece, I think it would be worth whoever's leading on that to have a chat with Omar in relation to some of the technology that's available now around that, which could be a significant saving for us in terms of staff time, but also in terms of improving the ease at which we undertake medicine optimisation. Any questions for Helen before I pass across to Jonathan? Jonathan, performance.
Do you want me to cover performance now, or in relation to planning?
Planning, not performance.
Could do either, Chair. So just
wrong P. Sorry.
Just on planning, I think Helen's given a really good summary of where we are, but worth the board noting that the planning guidance was produced on the 30th of January. There's a really intensive programme of work ongoing that many board members have been involved in, including regular meetings with NHS England, and we hope to put in what we hope is a final submission on the 27th of March, so next Thursday, and of course once we have clear plans for the year ahead, we will share them in public in the board meeting. So that's probably all I wanted to add on planning.
Thank you, Jonathan. Now moving across to quality and performance, and I'll ask Masood Ahmed, our chair of the Quality Performance Oversight Committee, to kick off this, and then I'll hand across to Elaine and then back to Jonathan again.
Thanks, Chair. So I'll take the paper as read. It's an update on the committee meeting that occurred on the 12th of February. Elaine and Jonathan will take you through the reports addressing some of the key quality and performance challenges across South West London and outline the actions that are being taken to address them.
Thank you, Masood. Any questions from Masood before passing across to Elaine? Elaine.
Thank you. As always, the Quality and Performance Committee is well attended and lots of conversation and discussion. I'll just highlight, colleagues, to the continued IPC challenges, which the committee talks about across all of our provider organisations, and some of the challenges around that. We had a paper on prevention of future deaths. Just to highlight to colleagues that we're seeing an increase in prevention of future deaths, both for the ICB, which is new, but also to our provider colleagues. That's a theme that's across the capital and the country in terms of coroners issuing more prevention of future deaths, but it's important that colleagues know that there is an increase and why, and how we're learning from those themes and how we're assuring ourselves and working across the system with those. In terms of quality, of course, we talked about the urgent emergency care pathway and the challenges around that from a quality perspective. Jonathan will pick up from a performance perspective, I'm sure. Note CNST for maternity services have just been submitted for South West London, and we continue to make good progress and sustain where we're at with that. And some ongoing work around patient safety reporting and shared learning, and the community of practice in South West London continues to grow in strength and what it does in terms of sharing the learning for patient safety, but also working on patient improvement of patient safety, which is good. I think it's important to say that the Quality Committee will have an increasing role going forward when we've talked about some of our financial challenges in terms of that assurance about quality impact assessments for some of those very difficult decisions that we're making. I'll hand over to my colleague in terms of performance.
Question on quality.
Yeah.
I was going to ask you about the prevention of future deaths. There's clearly a theme there, mental health, in terms of what we're seeing. So can you say more about what action we're taking, what thematic learning we're taking from the cases in that regard? Because a lot of them seem to be relating to young people not getting access to services in a timely way, and in the context of what we're describing in the planning round. I just wondered what your thoughts were in that regard.
Yes, thank you. It is difficult, and it is a theme that's being picked up by coroners up and down the country. We're seeing. We work very closely with South West London, St George's, and of course SLAM colleagues in terms of those prevention of future deaths, and work together on picking up those themes and the learning and how we can support the changes in pathways and the change in priorities of the waiting lists. And I can see Vanessa's nodding. I'm sure Vanessa will add into that. But that group of sharing the learning from those prevention of future deaths, both for us locally but also across London in terms of how as systems we're sharing some of that. Vanessa, did you?
I think just to add in addition to what Elaine was saying, the experience of being in a coroner's court at the moment around their threshold for issuing prevention of future deaths, and the way in which they are using their ability to hold both organisations and systems to account is different from what it was 3 years ago. So I'm not going to go into the individual cases, but just as an example, one of the future prevention of deaths that we got issued was around having a smoking shelter, making sure we had a smoking shelter on NHS properties. I'm not able to do that because we're not allowed legally to do that according to the mandate, but a prevention of future death order was still issued. So there are a number of these cases. I think collectively, though, the learning around waiting times within mental health provision is a significant risk for all of us to hold. I hold, as do my colleagues at SLAM, real significant challenges and high levels of risk in the community provision for both working age adults and community services, and that manifests itself, I suppose, most clearly when someone is in an acute crisis and decides to take and makes a decision to take their own life, very tragically. And this is the work that we've looked at as an ICB board through the mental health strategy and through the commitments we've made in the longer term. But I think in the shorter term, our coroners are highlighting a real risk with waits in mental health provision that aren't as transparent as in other areas of the health system.
Thank you for that. Jonathan.
Thank you very much, Mike. So again, I'll take the report as read, but just to pick out a couple of positives and a couple of areas of ongoing challenge. So our access rates to childhood immunisations remain well above the London average, as does our primary care access, which is obviously a vital metric in the planning guidance we've received, as does our Cancer Alliance performance against, including against the new 31-day treatment first stage measure. And I would also note our 4-hour performance, which is obviously a critical sort of shop window of the NHS, has improved significantly in March, and as of yesterday we are 1.01% above the 78% standard, not that I'm monitoring it closely. Whilst we've still obviously got some time to go in March, I did want to note the progress and the delivery of providers in that area. And then to note 2 areas of challenge as are highlighted in the summary paper. So for patients waiting 12 hours in emergency departments, which I've talked about here before, and the Quality and Performance Oversight Committee is going to do a deep dive into at its next meeting, and the concerns that Elaine and I and others have around the room about the impact of those lengthy waits on morbidity and mortality of patients. So wanted to flag that where we are challenged and amongst the most challenged ICBs in the country. And also similarly for mental health waits, for 12-hour plus mental health waits, whilst and it is important to note for the very longest waits, those who wait over 72 hours, we have improved by 50% since May last year. There are still far too many patients waiting far too long to access appropriate mental health support and awaiting emergency departments, which is obviously not an appropriate setting for them, not an appropriate setting, and it has impact for other patients and staff as well. And that's linked, of course, to the work that we're trying to do around mental health length of stay too, which is another big theme of the planning round. So I've tried to provide some balance between areas of strength and areas of ongoing challenge for us.
Jonathan, thank you for the light and shade. Matthew.
Yeah, just on the back of the long waits and potential real harm, there's a piece of work we've been doing in Croydon on a harm review in exactly that space, so something that might be shareable almost now for Elaine and colleagues to pick up on and add in from what has been done elsewhere. So it might be useful.
I have to say, we've done one in Lewisham and Greenwich as well, looking at the difference between the two hospitals, where there's very significant difference in length of waits, and there are some very dramatic findings in terms of the outcomes in the hospital where there are much longer waits in ED. Jacqueline.
We haven't mentioned it. Hang on, sharing. But we've had PSURF going on now for about, this is for Elaine, sorry, I've just realised this is for Elaine, not for Jonathan, going on for a while now. And I'm just wondering what learning we're getting from doing that. And have we looked at that?
Yeah, thanks, Jacqueline. We have looked at that. Some places transitioned sooner than others, so we've gone to, so we've done a big, we did a review with colleagues at CHS because they were one of the first to take on board PSURF and learnt from their journey, the good, bad, the ugly, and from that, which was really, really positive. Kingston have their PSURF review imminently. The Gesh group were a bit further down the line in terms of implementing, as you well know, so we will come to you later. But what we're doing is collating and working as partners, and all of those reviews are multidisciplinary and from the different trusts, so that shared learning happens, and that's where it feeds into the patient safety community of practice group that we've got, which is actually chaired by Mary Hopper, so not from an ICB colleague, so that the learning follows through.
Mary Hopper, my Mary.
Your Mary. Yeah.
Brilliant, thank you for that. We'll move on to audit and risk, and the chair of that committee isn't here, but Ben, we did have a meeting on the 10th of February. You may want to just draw anything from the report. Helen.
Yes, thank you, Chair. So in the main, the meeting was about getting prepared for the year end. So we had a good discussion about the annual report and our approach to pulling that together, led by Charlotte's team, and obviously the finance team from the annual accounts point of view. I think the key thing to note that there's a series of CLOEs that NHS England uses as part of the annual report that they then test us against. So it's really key that we make sure that we address those within the documentation, which arises between the balance of the detail to write to be able to meet the CLOE versus actually making it a succinct report that the public would want to read and see. We also looked into a deep dive around the workforce risk that you've seen in the BAF today, and around what that looks like and what that feels like to really interrogate into that. And then we had the general updates from internal audit, external audit, counter fraud, and our own accounting policies and approaches and key items to recommend for the committee to review, ready for the year end.
Thank you. Any questions for Helen on the audit committee? Thank you. I will then move on to remuneration committee. If I could go to Anne Rainsbury, the chair of the committee, just to finish off the suite of committee reports.
People have got the paper and can take it as read. I'm just happy to take any questions that people might have about the items that we've dealt with.
Thank you, Anne. Any questions? Nope. In which case, we'll move on to the Chief Executive's report. Katie.
Thank you very much. I was just going to report briefly on 3 items. Obviously, it's been a slightly unusual first month into the organisation. The first point to touch on, we've covered a little bit in this meeting already in terms of the point we're up to in the planning round. So obviously that has been an incredibly intensive process to this point. And again, my thanks to all partners around the table who have, at very short notice, reprioritised work that we could do collectively to refine and get more detail and substance behind our plans, which I think puts us in a better position heading into our regional scrutiny meeting, which is tomorrow morning, which will be held in advance of a board-to-board meeting with the national team in April. We haven't got that date confirmed yet. So we've covered that, I think, in terms of detail, so I won't speak in any more detail, but just to note that that has been really very time consuming from not just ICB colleagues but also the broader ICS system over the last few weeks. The second one, I think it would be disingenuous for me not to make note of the national announcements that have been proliferating over the last few weeks, certainly since my arrival. I don't think the two are linked, I hope not. But nevertheless, we recall right at the beginning in the early days an announcement that a further 15% reduction in headcount from NHS England was coming. And then followed on the heels was a 50% reduction in NHS England, and then followed swiftly with ICB announcement around 50% reduction, and then hot on the heels, I think less than 24 hours later, the abolition of NHS England. So this is an ever-changing picture, but I wanted to note at this point that actually trying to land an incredibly challenging planning process, as well as the system having to land a new chief executive, which thankfully hasn't had to happen in this system too often, as well as having to manage the huge amount of uncertainty, I think is placing incredible additional pressure on all of those colleagues working across the system. Sorry, the other announcement I should have added that came hot on the heels of the abolition of NHS England is the requirement of all provider trusts to reduce growth in their corporate overhead by 50%, but the baseline is not yet known against which that 50% is reduced. So to say it's fluid is probably a slight understatement. So we are working and having to respond. I just wanted to note at this point that actually I was humbled and deeply impressed actually last Thursday when I had to do my first staff briefing to all ICB colleagues, and actually quite a lot of place colleagues, so not just ICB staff on that call, where we had to arrange that call at less than 24 hours notice. At its peak, we had over 550 people on that call, and despite me having to deliver as my first all-staff briefing some really difficult messages with absolutely no detail behind them, the response from them was, as I say, incredibly humbling, incredibly professional, very thoughtful, very pragmatic, and wanting to just keep going and get on with the really, really important work that we're doing here in South West London. So I think as a board we should be incredibly proud of the colleagues in all of our partner organisations who are genuinely trying to pull together to do the best they can, which is perhaps counter to some of the messaging that's in the media at the moment in terms of the role that we all play. But I had very, very personal first-hand experience, and we should note the professionalism and pragmatism with which those staff responded to what's very difficult messaging. So that's all I wanted to say about that. And then the last thing I think to note, I know it's been well rehearsed here, but on the 1st of April, obviously we formally received delegation for specialist commissioning. Those agreements have now been signed. Big question is, whose headcount are they, I guess, as we head into 25-26, but we should just note that the agreements that have been to all of our board meetings have now been signed, and that is progressing as planned for the 1st of April. But happy to take any questions in any other areas.
Katie, thank you. And they often say it's all about timing, and we possibly could have picked a better time for you to start as Chief Executive, but I'm personally really grateful for the way in which you handled the announcements. I've had unsolicited a number of staff coming up to me and saying how refreshing the news was. Very difficult to hear, but how refreshing in terms of the openness and the way in which we engage with staff. So thank you very, very much, Katie. We'll now move on to any other business. Can I check with colleagues whether or not there is any other business? I've not been notified in advance. In which case I'll formally close the meeting and we'll open it for questions from the public. Wendy, I can see that you already have your hand up. Let me make sure we get a microphone to you.
I've been coming here for over 2 years now, and I say mostly the same thing, and I notice that there doesn't seem to be any progress on the specific things that I speak about. My name's Wendy Micklewright. I hallucinate, I hear voices, I'm not ill, I don't take psychiatric drugs, I'm dyslexic, I'm involved with a community group that gets no funding from anyone. We're free, confidential, all welcome. We're affiliated to the Hearing Voices Network. And because we're confidential, I can't tell you some of the situations that have arisen, but there is some ideas out there that organisations like this one and like councils, their job isn't necessarily to deliver services. Their job is to empower people in a way that is strength-based, rights-based, integrated, person-centred, and that's what we strive to do. So if I go through, if we focus on human rights, which is something that Michaela Amoring says, if we focus on human rights, we can achieve great things, hopefully. So I've come to this meeting, I've told people that I think it was 2018, the UN published a report which said quite clearly, if you put electric shocks through our bodies without our informed consent, it is torture. And I've suggested things like people assemblies to discuss this point. It's very clear from the information we collect using the Freedom of Information Act that electroconvulsive treatment is a sexist practice. When some people challenge me on this, they say to me, but women are more likely to get depression than men. That, again, in my opinion, is a sexist statement, because the Office of National Statistics clearly states that if a household is getting an income of about £10,000, they are more likely to exhibit what's known as depressive symptoms than if they're in a household with an income of £50,000. So there's another book that I noticed, which is called The Age of Diagnosis. And repeatedly I suggest to people that they acknowledge James Davis's work, Cracked, Why Psychiatry is Doing More the Harm Than Good, and Sedated, How Modern Capitalism Created the Mental Health Crisis. And I think if you look at those works, you will see what the arguments we are presenting are. And within living memory, homosexuality was a mental illness. So we need to think about these things very carefully. We need to think about the way we do things. The UN and the World Health Organization said that the mental health system globally needs to change radically. And they put forward organizations like the Hearing Voices Network and said that that is a good way forward. So then we also know, and something I have said repeatedly at this meeting, is the UN and the World Health Organization says there needs to be an end to coercive practices within the mental health system. We have gathered the data, it is on our website, and it clearly shows the problem, and it's not getting any better. And when we talk about coercive practices, we mean forced imprisonment, community treatment orders, forced medication, face down and general restraints, seclusion, and we're also talking about electroconvulsive treatment. There's been a lot of talk about community involvement, and I just one more thing I'd like to say.
That would be good, thank you.
Yes, but this is the problem I have, Mike. I speak, but I'm not listened to, and it's not just me, because there, as you know, I've said for 2 years now, there's a petition that says over nearly 137,000 people said that there should be an end to electric convulsive treatment. And yet the people in this room hold on to that. And was it the same type of people who held on to giving us lobotomies 50 years ago? Saying that if we were homosexual, we were mentally ill? And that narrative is coming back.
Thank you, Wendy. You know there'll be people here to talk to you afterwards if you wish to talk to them privately as well. We have had two written questions. The first is from Syed Abra, who's a client director at Limbic. As the adoption of AI continues to shape the delivery of mental health care, what is the ICB's approach to leveraging these tools to enhance outcomes, improve efficiency and ensure equitable access to services? Additionally, if you're a third party that is able to support the ICB's strategy and priorities, who would be the best person to contact regarding this matter in the first instance? I would normally pass this question across to John, but in his absence, I'm going to ask Katie if she wants to say who Saeed could get in touch with. It probably will be John, won't it?
It will, but if he gets in contact with me, I'll make sure that that we connect up with the right person outside of this meeting. So yeah, because it might well be Martin who's here.
And Vanessa, did you want to say anything? Because it was sort of specifically around AI and mental health care.
Yeah, so I can add to it. So for both South West London and St George's and SLAM, we are working with software suppliers, exploring and piloting a number of AI technologies to improve both productivity, outcome and access to our services. That includes ambient voice AI-powered technology with capability for clinical consultation, generative AI incorporating large language models to automate the recording and minuting of non-clinical meetings to release time, and enhanced and virtual reality products for the delivery of certain forms of psychological therapies and other treatments, particularly for children and young people. And in fact, I met a service user only last week who had just completed their very first virtual course, allowing them to become a mechanic. So he was going to be discharged from our forensic provision with qualifications in mechanics. So, so we are happy to have further conversations if people would like. Thank you.
Great, thank you. That was a really good news story about... yeah, fantastic, fantastic. We've also had a question from Mark Forbes. Is Mark Forbes here? Yes. Mark, do you want to... We'll get you a microphone. Rather than me read out your question, okay. I think you had a follow-up question as well.
I did, yes. First of all, I'd like to thank the board for all its hard work that it does across 6 boroughs. It's obviously very challenging work you do on limited and sometimes unpredictable funding. I've taken the trouble to read your minutes from the January meeting you had and got a flavour of some of the hard work and some of the problem areas that you encounter. But at the moment, I wanted to ask a question in relation to staffing, which is a difficult area for any board or any organisation to deal with, because not only is there cost, there are supply chain problems too often with colleges not having enough staff to actually make available to employ. But I'd wanted to ask, in the context of actually a family member who's having a treatment plan between the Nelson Health Centre and the Wilson Hospital, which is going sort of okay, but not completely well as it should. How many clinical psychiatrists and ADHD titration nurses are employed across each of the 6 boroughs that you serve, and whether you're kind of building recruitment and retention and forward planning and other support for these people into your kind of thinking as your work goes forward. The reason why I ask this is because when I've asked managers or had short conversations with managers, the impression I get that in each borough there's sometimes only one ADHD titration nurse working. And against the background of a 2.5-year wait for ADHD medication from already diagnosed people, it seems rather unjust and unfair, because you and I all know that if we need to see the nurse, typically within our local healthcare practice, we'll get attention within sort of 2 to 5 days often, which is very, very good. But it seems that there's a mismatch, really, that people who have mental health conditions that are clinically diagnosed and who are often having to resort to coping strategies which are both very damaging physically to their bodies and very expensive to both themselves and the community, are having to wait so long. So I would really like some really kind of careful attention to be given to this area, and I want to know how many professionals really are employed in these key areas across the 6 boroughs, please. Thank you.
So, well, thank you very much for that question, Mark. And on the specifics of the transfer of care between the Wilson and Nelson, I might get that taken outside of the meeting and ask Mark to pick up on that, because that's sort of his patch. But Vanessa, you may not have the exact figures, but you'll be able to provide Mark with a general picture.
Sorry, hi Mark. I'm into the detail, but I haven't got the exact numbers with me today. But I will be able to provide them. It will take me some time. I need to do it across all 6 boroughs, including Croydon, so I can come back to you. What I can say is that our vacancy factors across our provision have improved by over 20% in the last year. So we have an improved vacancy position, which is leading to greater fill rates. So it's not a question of just filling the positions. There's a national workforce review for ADHD and autism that's being undertaken at the moment. That's due to complete in June this year and then report in September. So we'll have early findings from that we can also play in. Our waiting times are significant, which is what your waiting times for access and treatment are a significant challenge for us, and one that the board here has taken is aware of. It's a national picture, and I think you've highlighted very clearly that people's lives are suffering as a result of this. So we'll continue to advocate on your behalf. But I'll come back to you with the specifics to the questions that you've answered. I think you've submitted in email as well, so I'll be able to come drill down. I only received that this morning, so I'll bring it back to you.
Okay, so thank you. The other thing was the questions are asked within the context of back in 2017, the then healthcare secretary Jeremy Hunt allocated 1.7 billion, which sounds a lot of money, but when you look at the cost of employing key healthcare staff, that's a fund divided between the then 207 CCGs were created to something like 8.2 billion per CCG. There are now 42 of you guys around the country in your groups serving the nation, and I'm sure I don't have party or any information about your funding streams, but I know they're bound to be difficult and hard to predict. The other thing also is that I've learned from reading House of Commons paper that spending on mental health care provision isn't ring-fenced, but I discovered that with the mental health care investment standard, that acts as a sort of check and balance to make sure that the right sorts of funding are going into that area, which I'm reassured about. The sorts of NHS England claim that they've met their standards every year since 2015-16, but within the local areas there's some discrepancy about this report I read from the House of Commons by a lady called Catherine Garrett, I think it was, that said that the local areas didn't meet their targets in the years, I think it was 22-23. But in response I had from the St George's Mental Health Care Trust was that they actually had met their target, and you had the audited figures, so I'm inclined to believe those rather than the other report. But I'll say I've said enough, and I thank you for your ongoing work, and I look forward to some more specific answers about the numbers on those 2 areas. Thank you.
Mark, thank you for both questions, but with regard to the latter question, we have just made a decision in the Part 2 meeting which is confirming that we will continue to meet the mental health investment standard in the forthcoming year in spite of the financial challenges. In terms of historically, we can probably, the ICB has been in existence since 2022, so we can report back on that data. Helen.
Yeah, so the way it works is obviously our accounts are audited, so the 22-23 accounts were audited, and the external auditors confirmed that they were correct and appropriate and fair reflection of our spend. We then get an independent audit, particularly around MHIS, to ensure that we have put the right amount of money in line with the requirement as you outlined there, based on the percentage uplift that gets nominated to us through the planning round. I can confirm for 22-23 we had that external audit. It is on our website, and it confirms that we actually put in a 7.1% uplift against a requirement to do a 5.52% uplift. So we actually did more than was required. We have made sure since that time we've done at least the same amount. We are currently being audited against the 23-24 accounts, but we do not expect that to say that we haven't done anything but kept to that standard. And I think it's been really important that we've worked with our partners to invest in mental health and to make sure that we do that.
Thank you very much. I very much hope that the board can actually make itself a target to be a flagship for other boards around the country to meet targets and get ahead of the game. Thank you.
Thank you very much. Can I ask if there are any more questions from members of... Yes, please. Could you introduce yourself?
My name's Graham Kennedy. I'm a member of the public. I'm also part of a community organisation. I'm just interested to understand what happens with the what matters most to our community's work, and whether the kind of customers of the work are required to respond in any way, or whether it's at their discretion whether they take your market research on board, and whether community organisations that are involved in improving access to mental health services might have sight of what you've done, so that we can shape some of our offerings around the insights that you can provide.
Charlotte, if I could go to you.
Well, thank you for your question. Yes, so really important is that when we engage with communities, we go back and say, you said we did. So that's what we'll be doing with the Winter Engagement Fund, the 10-year plan. The analysis of the 270 reports is a bit more difficult, but we will be communicating that back out. If you're not on our mailing list, I will take your email, add you to our network, and then we can hopefully help each other going forward.
I actually meant the other way round. So you're doing research on behalf of the partner providers. So what do they do?
Yeah, so I suppose you're talking about impact, really. So it's the kind of so what question. So another good question. So we're plotting a governance path, basically, because these findings are pretty fresh. So they're only like literally a week or so old. So we'll be going to all of the decision-making meetings at Place and at South West London, presenting the findings, and then working with programme teams around kind of future plans going forward, and delivery of day-to-day services. And part of our governance is around, before decisions are made, and you'll see on the cover sheets, we ask all lead organisations and lead directors, how have patients and communities been involved? So people have to demonstrate that before we make any decisions.
Thank you. Any more questions? Yes, please.
Hiya. Giles, just a resident of Wandsworth. I just wanted to find out, quick question around Wandsworth's plans, or the ICS's plans around CDCs, and where I could read more information about that.
So I will go to Mark, but we have 3 CDCs planned for South West London, none of which are in Wandsworth. So Mark.
We do have one.
Oh.
That's St Mary, Queen Mary.
Yeah. Sorry, Queen Mary's. I'll hand it over to one of my executive colleagues rather than make up the answers.
Jonathan will correct me if I'm wrong, but the CDC programme is across South West London, and actually we do have a site in Queen Mary's Hospital, which is in Roehampton, which is accessible for Wandsworth residents. The route into that is usually through GP, etc. So we do have a site. It is accessible. People do refer into it.
Thank you. Any more questions? In which case, thank you all very much for your questions. And colleagues, thank you very much for your contributions to today's meeting. And look forward to seeing you in 2 months' time. Although I suspect we shall actually be seeing each other sooner than that. Okay, thank you all. That's the end of the meeting.